frequently asked questions and answers. When using the ECU2 and corridor flange together, is the entire floor, unit, or corridor being isolated, taken to negative pressure? No, the ECU2 with corridor flange will not provide enough negative pressure to take a large area to an airborne isolation status. The ECU2 with corridor flange will be negative to both sides of the installation and will provide an airlock for the transfer of staff and patients into the isolated unit. The engineering staff of the organization will need to work with infection control to determine which locations can be converted to negative pressure to the surrounding areas. This may be accomplished by modifying the mechanical ventilation system or by placing large fans and windows within the unit to create a negative pressure. The ECU2 and corridor flange can be used to create rapid response, scalable, indoor mass isolation. What are the primary differences between choosing indoor versus outdoor isolation? There are a number of factors which distinguish the choice of treating large numbers of people inside the healthcare facility versus outdoor, all relating to the acuity of care provided, the number of patients needing treatment, convenience, and cost. The benefits of choosing indoor mass isolation are that the healthcare facility is an established, optimized infrastructure with emergency backup power supplies, medical gas, lighting levels, vacuum pumps, and communications. Has easy access to other critical services such as medical supplies, central sterile supply, toilet and bathing facilities, clinical services, food service, and staff charting and documentation areas. Is capable of dealing with privacy issues under HIPAA regulations, such as being able to separate children and adults or females and males, and can avoid many patient and staff comfort issues related to temperature or other inconveniences caused by the effects of weather. The total cost of any outdoor solution for mass isolation must also factor in the total number of units, the supporting medical and mechanical equipment, toilet and bathing facilities, staff support areas, along with the response time in setting up the tent city. How does using the ECU anteroom or ECU2 to create individual patient isolation differ from placing portable air scrubbers in the patient room? The short answer is method of conversion, convenience, and cost. The ECU anteroom and ECU2 create a temporary negative pressure airborne infection isolation environment by pairing the unit with a 99.99% efficient HEPA-filtered negative air machine with a minimum of 600 CFM and securing it to the door frame immediately outside the room being converted. The return air vent in the room needs to be covered, and the supply air, along with at least an additional 200 CFM of air, is drawn out into the ECU anteroom or ECU2. This air is filtered through the HEPA-filtered negative air machine and safely discharged into the corridor. A freestanding portable air scrubber, by contrast, is positioned in the patient room as near to the patient as possible to capture the airborne infectious droplet nuclei. In order for this solution to provide a temporary negative pressurized room, the unit needs to be ducted directly to the outside of the building. In most cases, this ducting needs to be pre-installed and often requires breaching the building envelope. This will require predetermining the location of the rooms to be converted and requires an outside wall. The benefit of using an ECU as a negative pressure airlock for a negative pressure environment over a freestanding in-room air scrubber is that this method can be used on virtually any room in the facility and eliminates the need to make modifications to the exterior of the building. The ECU eliminates those challenges and risks, as well as the need to pre-designate in advance of an emergency exactly which rooms will become converted rooms. When using either the ECU anteroom and the ECU2 to create individual patient isolation by securing the unit to a patient room door and attaching a HEPA-filtered negative air machine at minimum of 600 CFM, is it safe to discharge the air back into the hospital corridor? Yes. The CDC expressly permits the recirculation of HEPA-filtered air back into patient-populated areas. A typical hospital patient room and corridor is filtered at 90% efficiency, much lower than when filtered through a HEPA filter, which captures a minimum of 99.97% of all airborne particulates. HEPA-filtered air is the cleanest air in the healthcare organization and is used in bone marrow transplant rooms, cardiac and orthopedic operating rooms. Will using the ECU anteroom or ECU2 for individual patient isolation violate the NFPA's Life Safety Code referenced by the Joint Commission and Centers for Medicare and Medicaid Services? No, the Life Safety Code deals with permanent installations, and the ECU anteroom and ECU2 are temporary solutions for use in an emergency or for infection control purposes. The ECU anteroom is only 28 inches wide, while the ECU2 is 34 inches wide, so in a standard 8-foot 0-inch corridor, there will still be plenty of room to maneuver beds, gurneys, crash carts, environmental service equipment, and other equipment. The lightweight nature and ease of use of the ECU enables rapid repositioning in times of crisis or special needs. The healthcare organization will need to implement interim life safety measures and have an action plan to move the ECU in the event of a fire. Does the ECU anteroom or ECU2, when used to create isolation, need to be tested with a particulate counter after it is initially set up? Yes. Although Mintie Technologies has extensively tested the ECU product line with the help of industry-leading environmental infection control experts, it strongly recommends that when used to create isolation, each setup of the ECU should be tested. The negative air machine needs to be tested with a particulate counter to assure the proper sealing of the HEPA filter, and the ECU needs to be checked to make sure the room is at a negative pressure. The CDC EIC guidelines require every isolation room to have its pressurization checked before a patient is placed in the room, and then daily when the room is occupied by an infectious patient. This test can be accomplished using a flutter strip, smoke tube, or a handheld manometer. What are the primary benefits of using the ECU sealing cavity, ECU anteroom, or ECU2 and corridor flange in place of plastic sheeting and poles? The ECU provides a number of benefits over plastic sheeting and poles. The prefabricated standardized nature of the unit provides a consistent containment application every time. Its structural integrity can dramatically reduce risk exposure associated with poles that may collapse or tape that may peel away, and built-in negative air ports facilitate negative air compliance in a rapid manner. The portable collapsible nature of the unit makes it easy to use and results in faster setups and breakdown. This and its cleanable reusable envelope can deliver significantly lower labor and material costs over the life of the product.